I'm back again. This is Dr. Tatum, and I left off on slide 10 talking about preterm labor. And so what I'm going to do in this 15-minute video segment is complete the rest of preterm labor and then hopefully get through premature rupture of membranes. So again, bear with me. Thank you for being flexible and patient. I so appreciate it. All right, so with this slide, we talked about the diagnosis of preterm labor a little bit before. So again, preterm labor is gestational age between 20 and 37 weeks gestation. And in order to fully diagnose preterm labor, we have to have specific criteria in place. And so again, uterine contractions are usually in place. A lot of times these uterine contractions are going to get stronger and more painful for the woman. Also, you're going to see cervical change. Because of those contractions getting stronger in nature, that's also going to lead to cervical change. So again, a lot of times you're going to see effacement of at least 80%. Remember, effacement means the thinning out of the cervix and the shortening of the cervix, and cervical dilation of 2 centimeters or greater. So that is how we define what preterm labor is. All right, moving on. I really like this next slide, slide 11. It's just a visual aid, and it just shows you the different sizes of cervical dilation. And so again, you can see 2 centimeters is about the size of a penny. 4 centimeters is the size of an Oreo. 6 centimeters is the size of the top of a soda can. 8 centimeters is a donut. And then 10 centimeters is a roll of toilet paper. So I'm sure you're never going to look at Oreos and donuts the same way again, but I really like this visualization because it does show you how that cervix dilation occurs. Okay, moving back to our slide, we're going to talk about slide 12 now. Lifestyle modifications. Oftentimes when a woman experiences preterm labor, we are going to put her in a more modified bed rest situation, meaning that she can have bathroom privileges. She can get up and use the bathroom. She can still shower. She can still get up for meals, but really a lot of restrictions are placed on her. Prolonged bed rest, we don't really like to use because there's lots of different research criteria that shows that prolonged bed rest is not the way to go, just because it can cause lots of different other physiologic disruptions in her body, like weight loss, muscle wasting, or weakness. It can really demineralize her bones and make her bones weak. She has an increased risk for clotting factors. So like a DVT. It can lead to sleep disturbances and just overall generalized fatigue. She may not be able to sleep very well at night. And so again, it's usually modified bed rest is what we look for, and really what we try to stress for her if possible. As far as other things, restriction of sexual activity, we don't want anything in her vagina. That's really, really important because sometimes if sexual intercourse occurs, that can stimulate the release of prostaglandins, which causes more inflammation and it can make her contractions stronger. So we just tell her no, no more. Also, home modification, home care, just making sure that things that she needs are within reach so she's not getting up and down periodically. So that's, again, just making sure that she has everything she needs close by. All right, so moving on. Let's talk about some of these medications because these medications are important. I do think it would be wise for you guys to understand how we use some of these medications and really their purpose, their overall purpose. I do want to refer you to your textbook because there's a great chart in your textbook on it starts on page 685 and it goes to about 687 or so. So use your textbook because these medications are right here in this chart and they are pretty important medications. So the term tocolytics just means that these are medications that we give to a patient to help basically relax the uterine muscle. We don't want it to contract anymore, so we're just going to relax it. And the very first drug that you're going to see listed is mag sulfate. This is probably one of the most commonly used medications for preterm labor. It does promote the smooth relaxation of the uterine wall by competing with calcium in the cells. So again, overall, it relaxes the uterine muscle. It also depresses our central nervous system. So if it is a CNS depressant, what would be some side effects of this? Can you think of any off the top of your head? I'll just give you a minute or so to think about it. It is a central nervous system relaxant or depressant. Most women that are on magnesium feel terrible. They feel really sick. They feel really, really fatigued. They feel like they've been hit by a semi truck. Seriously, they feel awful. Um, what they most likely will experience might be hot flashes, fatigue, um, sweating, nausea, vomiting, muscle weakness. Some women might experience blurred vision. They might have some headaches. A lot of times, maybe some dizziness or hypotension if they're sitting up in bed. And the big thing that we really, really look for is respiratory depression. Just because it is a CNS depressant, a lot of times it can slow down the rate and depth of respirations, and we really look for respiratory depression in these patients. So oftentimes, if magnesium is given to a mom, and a lot of times magnesium is given, it's given IV route, and a lot of times it's via pump just because it is a potent medication. We always want to deliver it safely by an IV pump. And what we're going to do is we give a 4 to 6 gram loading dose of magnesium to the mom over 20 to 30 minutes. And then she's put on a maintenance dose of magnesium, anywhere from 1 to 4 grams of magnesium per hour. And then she is on this for a good 24 to 48 hours. So it is short term in nature, but it makes her feel terrible. She does get magnesium levels drawn, so we can check the therapeutic level of magnesium in her blood every 6 hours. And we want that magnesium level to be between 5 and 8 milligrams per deciliter. That is the goal. If she has more of a toxic amount in her blood, it's going to be anywhere from 9 milligrams per deciliter or more. So toxic, I want you to think of respiratory depression. So she's going to basically slow down her respirations. She's going to have acid-base imbalances. She probably could have some pulmonary edema associated with that because she's not breathing and opening up her lungs effectively. Absent deep tendon reflexes. That's something that we check routinely on moms that are on magnesium. And then also cardiac dysfunction. The big thing too is to watch urine output. Usually every hour we're measuring urine output. If she starts to decrease her output, then she's going to be at higher risk for toxicity. So that's something else to think about. Other medications would be beta adrenergics. So beta 2 adrenergic agonists like terbutaline would be something that we can give to suppress uterine contractions as well. What this drug does is it stimulates beta 2 receptors in the uterus, and it causes the uterus just to relax. It is kind of risky for moms just because it can selectively also activate beta 1 receptors that can cause tachycardia in patients. So moms that are given terbutaline, a lot of times they'll have tachycardia or they'll complain of heart palpitations. This medication can also cause pulmonary edema. It can cause hypotension in some women and also hyperglycemia. And so just some things to think about if you ever see this medication given. It can be given sub-Q. So we give it sub-Q, and again, always, always assess those lungs because it can cause pulmonary edema in these women. All right, the next one is nifedipine, also known as Procardia. You may have heard of this drug before. This is a calcium channel blocker. And basically, this will also suppress uterine contractions. It is rapidly absorbed if it's given orally. And again, it can cause hypotension. And then the last one is indomethacin. Indomethacin is a very potent NSAID, and this also suppresses preterm labor by blocking the production of prostaglandins. Remember that prostaglandins are involved in our inflammatory response. They are inflammatory markers. And if we suppress inflammation, and we can then basically relax our uterine muscle enough to stop any cervical changes that could be made. A lot of times indomethacin is pretty well tolerated by women, and so that's another reason why we give it. So again, use your chart in your book to help you understand some of these medications as well, or just contact me if you have any specific questions. We're going to keep moving on. Let's talk about glucocorticoids for these women. A lot of times we will give antenatal glucocorticoids because they will actually speed up the maturation of lungs within the fetus. And so a lot of times it will speed up the production of surfactant in the fetal lungs. And so we usually give this to women that are less than 34 weeks gestation. So again, it reduces the incidence of respiratory distress in babies. It does reduce the risk of necrotizing enterocolitis, intraventricular hemorrhages, and even infant mortality. And so again, glucocorticoids are really, really important, and we give them actually fairly commonly in labor and delivery. So really, the National Institute of Health recommends that we give these glucocorticoids anywhere from 24 to 34 weeks gestation. And a lot of times when we admit a woman, we give these right away if we can. We want to get them in. Some of the most common glucocorticoids that we give are betamethasone. So betamethasone, we give 12 milligrams IM times 2 doses, 24 hours apart. Or we can give dexamethasone, 6 milligrams IM times 4 doses, 12 hours apart. So oftentimes these women are hospitalized long enough that they can get these steroids in their system. So if we give it IM, we can give it usually in the ventrogluteal or vastus lateralis muscle. The injection is actually somewhat painful. It can burn or sting a little bit as it is injected into the muscle. And the big thing also, because both of these are glucocorticoids, it can really mess with a woman's blood sugar level. So just monitoring AccuChecks closely is important. In diabetic patients, they may need more insulin for several days after getting these steroids. All right, moving on. This slide just stresses that as labor is progressed to 4 centimeters dilation, a lot of times it leads to an inevitable delivery. So some women, they can progress fairly fast in labor, especially if that cervix is dilated and if that fetus is fairly small. And so nurses really have to be on board. They have to kind of know what to do, especially if a doctor is not present, because a lot of times doctors are not going to be on the unit. And so the labor and delivery nurses are usually the ones that have to be ready for an imminent delivery, and then also be able to resuscitate the baby if needed. So then I just want you to think about just an ethical consideration. At what lengths would you perform a resuscitation on a preemie? Just think about that. All right, I don't have much time left. I'm going to see if I can get through premature rupture of membranes. So premature rupture of membranes just means that the amniotic sac is ruptured. So there's leakage of amniotic fluid usually before 37 weeks gestation. A lot of times this is caused by inflammation. It can be caused by stress or infection as well. It can be a sudden gush of fluid or a very big gush of fluid. All right, you can see the results of this is usually a pathological weakness of the fetal membranes itself from those factors that we talked about. And the last part of this is chorioamnionitis, which is infection of the amniotic cavity. And some women will get this and they will get very, very sick.